Hello, and welcome to the Montana State University Prescription Opioid Education and Awareness Toolkit Module 1, An Introduction to Opioids. We are glad you have joined this presentation today, and we hope you gain information that you can take and benefit from. Before we jump into the module objectives, I would like to introduce you to the project team responsible for the development of this 5-module toolkit. The following Montana State University faculty and staff helped create the content and graphics of this toolkit. Michelle Grokey-Dewey and Allison Brennan served as principal investigators. Michelle is the Extension Family and Consumer Science Health and Wellness Specialist, and Allison is the Extension Family and Consumer Science Mental Health Specialist. This team is led by Program Director and MSU Extension Associate Specialist Barbara Allen. Other MSU Extension employees responsible for the content you are about to see include myself, Jennifer Munter as Program Manager, Barbara Watson as Program Coordinator, and Lori Maurer, Family and Consumer Science Administrative Assistant. At the conclusion of this module, we expect participants will be able to understand what opioids are and how they work in the body, understand the history behind prescription opioids and the opioid epidemic, identify the names of common prescription opioids, identify the side effects associated with prescription opioid use, identify the signs of prescription opioid misuse and opioid use disorder, and finally, identify the signs of an opioid overdose. We are going to start today out with some national and statewide data. This data provides us with a deeper understanding of the prevalence and impact prescription opioids have on Americans and Montanans. More than 232,000 Americans have lost their lives to overdoses involving prescription opioids between 1999 and 2018. Overdose deaths involving prescription opioids were more than 4 times higher in 2018 than in 1999. In Montana, in 2019, there were 48.2 opioid prescriptions written for every 100 Montanans. That's 1.5% higher than the national average of 46.7 per 100 Americans. In 2019, 10 counties in Montana exceeded this national average. In early 2019, a statewide survey of 379 Montanans was conducted by the MSU Extension Opioid Project Team. And findings included 65% of those respondents stated that prescription opioid use is a problem in their community. 52% of those respondents stated that they know someone who has used prescription opioids to the extent that it has affected their life. And 21% either currently provide care to someone who has a prescription for opioids or had one in the past. This data shows the need for community awareness and education across Montana. So let's kick off this education awareness by answering the question, what is an opioid? First off, you may have heard the terms opiates and opioids. Although these two terms are often used interchangeably, they are different. Opiates refer to natural opioids such as heroin, morphine, and codeine. Opioids refer to all natural, semi-synthetic, and synthetic opioids. An opioid interacts with opioid receptors on nerve cells in the body and brain and reduce the intensity of pain signals and feelings of pain. This class of drug includes the illegal drug heroin, synthetic opioids such as fentanyl, and pain medications available legally by prescription such as oxycodone, hydrocodone, codeine, morphine, and many others. Prescribed opioids are generally safe when taken for a short period of time and as directed by a doctor. But because they produce euphoria in addition to pain relief, they can be misused. Throughout this module, we will refer to this misuse as non-medical use of a prescription opioid. Opioid-based prescription drugs, whether they are natural, synthetic, or semi-synthetic, are designed to mimic your body's natural endorphins. When you use large amounts of prescription opioids, such as for long-term pain, the body produces more pain receptors, or docking stations, along nerve endings, thus creating the need for more prescription opioids to fill those docking stations. When opioids attach to pain receptors, they block the pain signals sent from the brain to the body and release large amounts of dopamine throughout the body. This release strongly reinforces the desire to take the drug again and again. Another issue with prescription opioids is they cause a decrease in the ability to create and utilize natural endorphins, thus losing the ability to reduce pain on your own. Prescription opioids are a class of drugs used to treat moderate to severe pain in some patients and are often prescribed following surgery or injury, or for health conditions such as cancer. In recent years, there has been a dramatic increase in the acceptance and use of prescription opioids for the treatment of longer-lasting chronic non-cancer pain, such as back pain or osteoarthritis. Despite serious risks and the lack of evidence about their long-term effectiveness, there are three categories of prescription opioids. The first category are natural opioids, including the prescription opioids morphine and codeine. The second category is semi-synthetic opioids. This includes prescription opioids such as oxycodone, hydrocodone, hydromorphone, and oxymorphone. And the third category is synthetic opioids, including prescription opioids such as tramadol, fentanyl, and methadone. Methadone can be used as a painkiller or to treat opioid use disorder. Methadone is highly researched, an FDA-approved medication used to treat opioid use disorder. Using FDA-approved medications to treat any substance use disorder, including opioid use disorder, is referred to as medication-assisted treatment. This will be covered in the preceding slides and modules. According to the CDC, in 2019, more than 36,000 deaths involving synthetic opioids, other than methadone, occurred in the United States, which is more deaths than from any other type of opioid. Synthetic opioid-involved death rates increased by over 15% from 2018 to 2019 and accounted for nearly 73% of all opioid-involved deaths in 2019. Pharmaceutical fentanyl is a synthetic opioid pain reliever approved for treating severe pain, typically advanced cancer pain as well as during or after surgical procedures. Fentanyl is 50 to 100 times more potent than morphine. It is prescribed in the form of transdermal patches or lozenges. Most recent cases of fentanyl-related harm, overdose, and death in the United States are linked to illegally made or acquired fentanyl, many times in pill form, not prescribed by a medical provider. Illegally made fentanyl is on the rise in the U.S. It is sold through unlawful drug markets for its heroin-like effect. It is often mixed with heroin and/or cocaine as a combination product with or without the user's knowledge to increase its euphoric effects. Reports from law enforcement indicate that much of the 10% increase seen between 2017 and 2018 in synthetic opioid overdose deaths may be due to illegally made fentanyl. Overdose deaths involving synthetic opioids were nearly 12 times higher in 2019 than they were in 2013. Heroin is a semi-synthetic opioid. It is both illegally and highly addictive. Its use has increased across the United States among men and women, most age groups, and all income levels. Not only are people using heroin, they are also using multiple other substances, including cocaine and prescription opioids. According to the CDC, nearly all people who use heroin also use at least one other drug. This practice is referred to as polysubstance abuse and is especially dangerous because it increases the risk of overdose. Heroin is typically injected, but is also smoked and snorted. When people inject heroin, they are at a much higher risk of overdosing, as well as risk of serious long-term viral infections such as HIV, hepatitis C, hepatitis B, and bacterial infections of the skin, bloodstream, and heart. Between 2006 and 2017, overall prescribing rates in the United States have decreased by 19%. However, this reduction isn't consistent across the United States, and opioid prescribing practices have been found to vary greatly at the county level. Certain characteristics seem to be present in those counties that report higher opioid prescribing rates. These characteristics include population size. Smaller cities or towns have been shown to have higher opioid prescribing rates, as do those who have a higher population of white residents. Also, counties with a higher number of dentists and primary care physicians per capita have higher rates, as well as those with a higher number of uninsured or underinsured residents. Lastly, those counties having a higher number of residents with disabilities, arthritis, or a diabetes, arthritis, or a disability are also shown to have higher opioid prescribing rates. A good understanding of history enables a society to learn from past mistakes and provides a framework for how to approach the future. When it comes to prescription opioids, the United States has a long history that has witnessed fluctuations in prescription opioid utilization and the problems that have resulted. In the early 1800s, German pharmacist Friedrich Serturner became the first to isolate and extract the alkaloid from the poppy plant, which resulted in the creation of morphine, named after the Greek god of dreams, Morpheus. Throughout the late 1800s, wounded soldiers were administered large amounts of morphine to treat pain. However, research suggests that the majority of those addicted to the substance were women, as they were diagnosed with pain at a higher rate than men. By the early 1900s, tens of thousands of Americans were addicted to morphine. By 1914, in response to both the emergence of street heroin abuse as well as morphine dependence, both physicians and patients were advised to avoid opiates. This avoidance continued into roughly the 1990s, when some in the medical community wondered why prescription opioids were avoided entirely for patients experiencing chronic pain. By 1995, the American Pain Society urged more aggressive and long-term use of prescription opioids for chronic, non-cancer pain. Simultaneously, Purdue Pharma released an extended-release formulation oxycodone, also known as Oxycontin. Between 1997 and 2002, Oxycontin prescriptions in the United States increased from 670,000 to 6.2 million. Shortly after, in 2007, Purdue Pharma pleaded guilty to federal charges related to misbranding Oxycontin and to misleading both physicians and the healthcare industry by overstating the benefits of opioids for chronic pain and for failing to state the risks. Since then, the United States has experienced extremely high levels of deaths related to prescription opioid misuse, now commonly referred to as the opioid epidemic or opioid crisis. Between 2013 and 2016, an emergence of synthetic opioids were seen. If you recall from an earlier slide, a synthetic opioid is a highly potent manufactured drug that mimics the naturally occurring opioids in your body called endorphins. One of these synthetic opioids, fentanyl, is 50 to 100 times stronger than morphine and was the cause of nearly 20,000 additional drug-related deaths in 2016. Given the severity of this public health issue, in 2019, numerous states began passing laws to help lessen the opioid crisis. For example, the Montana legislature recently passed House Bill 86, which limits first-time prescriptions to no more than 7 days. Additionally, it combats the doctor shopping that feeds addiction by requiring physicians to utilize Montana's prescription drug registry. According to an article from NPR News published in 2020, Purdue Pharma pled guilty to 3 felony accounts of criminal wrongdoing. The company is also likely to be reorganized into a public benefit corporation with profits from future prescription opioid sales expected to fund programs aimed at alleviating opioid use disorder. On the next couple of slides to come, you will see tables of the names of the most common prescription opioids. You may notice the terms agonist or antagonist. We will take a few minutes now to explain these two terms. An agonist is a substance which initiates a physiological response, in this case a euphoric high, when combined with a receptor. An opiate agonist mimics your body's natural pain-relieving endorphins. There are natural, synthetic, and semi-synthetic opioid agonists. These will be presented in the following 3 slides. In contrast, an antagonist is a substance that interferes with or blocks this physiological response. When blocked, the body does not experience the euphoric response to the prescription opioid agonists you are about to see on the next 3 slides. Because antagonist medications prevent the normal response the body has to opioids, they have been found to be highly effective in reversing an opioid overdose, as well as with the treatment of opioid use disorder. We will talk more in depth about antagonist medications in Module 5, Opioid Use Disorder, Treatment and Recovery Information. This slide provides a list of the natural prescription opioid pain medications. These include morphine and codeine. If you recall, heroin is also a natural opioid, but because it is an illegal substance, it is not included in this table. You will notice under the name column, both of these medications are considered agonists and work to activate the body's receptors, triggering that euphoric high. The other columns on this table provide you with the common brand names and street names. It's important to become familiar with both. Knowing the street names of common prescription opioid medications may help you determine if someone you know is using prescription opioids. Recognizing this may help prevent the use from turning into misuse or substance use. Morphine includes brand names such as Duramorph, Roxanol, Cadian, and MS Cotton. Street names for morphine include Miss Emma, Monkey, White, and White Stuff. Codeine has various brand names, and on the street it may be referred to as Captain Cody, Cody Lean, Schoolboy, Scissorp, Purple Drink, Doors and Fours, Loads, Pancakes and Syrup, and Lean. This slide provides a list of semi-synthetic prescription opioid pain medications. These are also agonists and include oxycodone, hydrocodone, hydromorphone, and oxymorphone. Brand names for oxycodone include Oxycontin, Percocet, and Percodan. On the street, it may be referred to as Oxy, Hillbilly Heroin, Perks, OC, Rims, Tires, and Greenies. Brand names for hydrocodone include Lortab, Norco, and Vicodin. On the streets, hydrocodone may be referred to as Vikes, Bananas, Fluff, and Hydros. Brand names for hydromorphone include Dilated and Exalgo, and on the street may be referred to as Smack, Dillies, Footballs, and Juice. The brand name for oxymorphone is Opana and may be referred to as Biscuits, Mrs. O, O-Bomb, or Octagons on the street. This slide provides a list of fully synthetic prescription opioid pain medications. These are also agonists and include fentanyl, tramadol, and methadone. Brand names for fentanyl include Atique and Sublamaze, and on the street you may hear it referred to as Apache, China Girl, China White, Dance Fever, Friend, Goodfella, Jackpot, Murder 8, Tango and Cash, and TNT. Brand names for tramadol include Ultram, and street names include Chill Pills, Trammies, or Ultras. Brand names for methadone include Dolphine, Methadose, Methadose Sugar-Free, and Methadone Discets. Street names include Chocolate Chip Cookies, Dollies, Fizzies, Wafer. The use of prescription opioids can have a number of side effects, even when taken as directed. Increased sensitivity to pain, constipation, nausea, vomiting, and dry mouth, sleeplessness and dizziness, confusion, depression, low levels of testosterone that can result in a lower sex drive, energy, and strength, and itching and sweating. Non-medical use of a prescription opioid refers to taking prescribed or diverted prescription drugs not in the way, for the reasons, in the amount, or during the time period prescribed by a doctor. A diverted prescription drug means a drug not prescribed to the person using it. Non-medical use is commonly referred to as prescription opioid misuse. The term misuse has recently been categorized as stigmatizing language, and the preferred terminology is non-medical use or substance use. According to the 2019 Montana Youth Risk Behavior Survey, over 1 in 10 high school students in Montana reported taking a prescription drug without a doctor's prescription. This is a good example of non-medical use and diversion, and clearly provides us with the haunting reality of the issue that is present in Montana and why education and awareness materials like this toolkit are critical to pass along. Potential signs that a person may be using prescription opioids in a non-medical way include extreme fatigue, changes in sleep habits, withdrawal from friends and family, poor coordination, shallow breathing, constipation, agitation, mood swings, depression, appetite changes, slurred speech, nausea or vomiting, irritability. As you can see, these signs can be physical, psychological, or even emotional. If you do notice changes in a loved one that seem to come out of nowhere, he or she may be struggling with substance use. When opioids are not used correctly, a person is at risk of developing an opioid tolerance. This is when the person begins to experience a reduced response to the medication, causing their body to require more opioids to experience the same effect. Another risk associated with non-medical use of an opioid is physical dependence. This happens when the body adjusts its normal functioning around regular opioid use, resulting in unpleasant physical symptoms when the medication is stopped. Also, when opioids are not used correctly, there is an increased risk of developing opioid use disorder. This is when there is a problematic pattern of opioid use that causes significant impairment or distress. A diagnosis is based on specific criteria such as unsuccessful efforts to cut down or control use, or use resulting in social problems and a failure to fulfill obligations at work, school, or home, among other criteria. Opioid use disorder is preferred over other terms with similar definitions, for instance, opioid abuse or dependence or opioid addiction. The non-medical use of prescription opioids and/or the use of illicit opioids like heroin or illegally manufactured fentanyl may also result in an overdose, which is injury to the body, poisoning that happens when a substance is taken in excessive amounts. An overdose can be fatal or non-fatal. All opioid-based drugs, whether they are prescribed or illegally acquired, are considered respiratory depressants and will drastically slow or stop a person's normal breathing, which can lead to death. It doesn't matter if the individual is a new or experienced user of opioid-based drugs, or if the individual snorts, injects, or takes pills. The risk of overdose is very real. Consider the slide on how opioids work in the body. Prescription opioids actually produce more pain receptors on the nerve endings, which then require more opioids to bind to these receptors. This increased use of prescription opioids causes the body to release large amounts of dopamine, which reinforces the desire to use the substance again and again. There are both short-term and long-term consequences on a person's physical health. Short-term include feelings of euphoria, dry mouth, headache, flushing, mental fog, constipation, drowsiness, itching, respiratory depression, and lethargy. Long-term effects include developing opioid use disorder, irregular heartbeat, increased risk of heart attack, fatigue, breathing problems, low blood pressure, chest pain, depression, severe constipation, severe abdominal pain, hormonal problems, weak bones, and an increase in pain. There are several mental health consequences when using prescription opioids in a non-medical way. They include anxiety, anger, depression, confusion, paranoia, mood swings, irritability, hallucinations, suicidal ideations, impaired judgment, loss of pleasure, and reckless behavior. If someone you know is experiencing these symptoms, there are several resources across Montana that can help. We have listed the Suicide Prevention Lifeline and Crisis Text Line on the slide here. You may also want to refer to Module 4, our Community Resources module, for more mental health resources. Using prescription opioids in a non-medical way not only has mental health consequences that can lead to many debilitating health and safety needs, the use also leads to societal and economic consequences. At the societal level, consequences include children being removed from the home, high rates of incarceration, car crashes, suicidal deaths related to substance use, overdose deaths, etc. At the economic level, the costs incurred because of these mental health and social consequences end up taxing the individual, their family and friends, their work life, their community, and societal systems like healthcare. As mentioned earlier in this module, when prescription opioids are not used in the way, for the reasons, in the amount, or during the time period prescribed by a doctor, there is a risk for the individual to develop opioid use disorder. Opioid use disorder is defined as a pattern of opioid use that causes significant impairment or distress. The term OUD is preferred over other terms such as opioid abuse, opioid dependence, or opioid addiction. In 2018, an estimated 2 million people had an opioid use disorder. According to the CDC, opioid use disorder has contributed significantly to overdose deaths among those who use illicit or prescription opioids. A proven and successful treatment of opioid use disorder is called medication-assisted treatment, or MAT. MAT combines the use of one of three medications, methadone, buprenorphine, or naltrexone, with counseling and behavioral therapies. For more information on medication-assisted treatment, see our bonus module on treatment and recovery. This module goes into more detail on the three medications used and how they work to help treat OUD. You can also learn the process physicians must take to offer medication-assisted treatment. Very recently, this treatment has been referred to as medication for opioid use disorder. Anyone who takes prescription opioids runs the risk of developing opioid use disorder, and in fact, as many as 1 in 4 patients receiving long-term opioid therapy in a primary care setting struggles with opioid use disorder. Opioid use disorder has contributed significantly to overdose deaths among those using prescription or illicit opioids. Opioid use disorder and overdoses continue to be a major public health concern in the United States, but are preventable. Signs that someone is experiencing prescription opioid overdose include small, constricted, pinpoint pupils, falling asleep or loss of consciousness, slow, shallow breathing or no breathing, less than 1 breath every 5 seconds, face pale and clammy, pale blue or cold skin, slow, erratic or no pulse, choking or gurgling sounds, limp body, no response when you yell the person's name or rub the middle of their chest with your knuckles. This information comes from the Montana Department of Health and Human Services Best Practice Medicine naloxone training course and the CDC Preventing an Opioid Overdose tip sheet. If someone is experiencing any of the following signs of overdose, call 911 immediately. Between the years of 2006 and 2018, more than 600 Montanans died specifically from opioid overdose. The synthetic prescription opioid medication used to reverse an opioid overdose is called naloxone. As you can see, naloxone is a prescription opioid antagonist. If you recall from the earlier slide, an antagonist is a substance that interferes with or inhibits the physiological response. Naloxone actually binds to opioid receptors, blocking the effects of other prescription or illicit opioids. It can be administered via injection or nasal spray. In 2017, Montana legislature passed House Bill 333, the Help Save Lives from Overdose Act, authorizing increased access to naloxone, an opioid antagonist used to reverse an opioid overdose. The law requires the Montana Department of Public Health and Human Services to issue a statewide standing order for pharmacists to voluntarily utilize for dispensing naloxone prescriptions. Under contract with the EMS and Trauma Systems Section, Montana DPHHS Best Practice Medicine is coordinating a statewide effort to train naloxone master trainers as part of the strategic plan to combat mortality from opioid overdoses. To learn more on how you can become trained to carry, administer, and train others, please visit the Department of Health and Human Services montana.gov website. The best ways to prevent overdose from prescription opioids is to improve opioid prescribing practices, reduce exposure to opioids, prevent use and non-medical use, and treat opioid use disorder. The next slide will discuss how to accomplish these strategies at the state, local, and individual. So what does prevention of the non-medical use of prescription opioids look like at the individual, local, and state levels? First, at the individual level, prevention, education, and awareness of the dangers of prescription opioid use and how to safely use, store, and dispose of prescription opioids is a good prevention method. At the local level, community prevention, education, and awareness opportunities like this one need to happen, and access to medication disposal bags, prescription drug drop box location sites, and community participation in the National Prescription Drug Take-Back Days would help ensure that unused prescription opioids are removed from the home and from the community. At the state level, increase and maximize the use of prescription drug monitoring programs, or PDMPs, which are state-run databases that track prescriptions for controlled substances and can help improve opioid prescribing, inform clinical practice, and protect those at risk. PDMPs help providers identify patients at risk of non-medical use of prescription opioids, those that are at risk for opioid use disorder, and those that are at risk for overdose due to overlapping prescriptions, high dosages, or co-prescribing of opioids with benzodiazepines. Also at the state level, funding for county and local organizations across Montana to provide prevention education is a good way to prevent the non-medical use of prescription opioids. According to the 2019 statewide summary report conducted by MSU Extension, 29% of rural Montanans keep their unused prescription opioids for 1 year or longer. To help get unused prescription opioids out of homes, you can find a Dropbox location site near you by visiting the Department of Health and Human Services.montana.gov link provided to you on the slide. If there is not a year-round location site near you, you may also visit the National Take-Back Day website at dea.gov in October and April to find a participating collection site in your area. If you cannot utilize either of these methods, at-home single-use medication deactivation pouches can be purchased and utilized. To get a free disposal pouch while supplies last, please visit our project website at the link provided on the slide and fill out the order form. More information about disposal methods will be presented in Module 2, Prescription Opioids and Home Safety, Proper Storage and Disposal. This concludes Module 1. For more information on prescription opioid use and misuse in Montana, you can visit our project website. Our website will allow you to access the other 4 modules and their PowerPoint presentations, the Native American Toolkit, and several informational and recovery story videos. You can also print and/or download our educational resources and order a medication disposal pouch while supplies last. If you have any questions, or if you know of an organization that would benefit from this toolkit or would like to present the toolkit to their communities, please email our Program Director, Barbara Allen. The Montana Department of Health and Human Services website is also a great resource for individuals and community organizations. Thank you for listening today, and we hope that you have gained knowledge and awareness on the topic of prescription opioids.